because it will take little time. And then sinus, syncope, chest pain, palpitation, pedal edema. All right, no significant past history. So what do you make out of this? Why is it progressing? In a PH, what are the reasons for progressive dyspnea?
So
why does the disease worsen?
PH, the disease worsens because with time the pulmonary vascular resistance increases, and because of the increase in pulmonary vascular resistance in the microcirculation, more and more capillaries, there is intimal hyperplasia, fibrosis. So changes occur in the microcirculation level. So
Something
they
like
cause.
that. Okay. So is this a usual story? 8 years. Is this a routine PH style or this is different? What do you think? What is the general understanding of PH progression?
Sir, this history was for 6 months only. She presented at 8 years of age.
No, but what Dr. Kothari is asking is from 8 to 16, the child has progressed relatively slowly, maybe on therapy, maybe not on therapy, different story. But is that long or is it short or is it average? This kind of a natural history or a course.
Sir,
now keep in mind such progression about disease, because that gives you some insight into the type of problem that we are handling. So most PH would progress like this, or this is slow, or what do you think?
Sir, this at 6 months it was usually they take 6 to 1 years, they show progression, and then it depends whether any management has been started. With management, the progression will slow down, but if there is no therapy which is started, then they can have more rapid progression.
I don't think therapy is known to change progression. See, no therapy in PH so far has shown to change progression of the disease. Yes, it can change symptomatology for a while. Patient may improve a little bit here and there, but they don't change the natural course of the illness. So the question is, he has not developed any pedal edema for 8 years, isn't it? He started at 8 years of age. His PH possibly started at 8 years of age. And by 16, he has not developed any pedal edema, no heart failure.
Yes, sir. Currently, she is not having any symptoms. This was at 8 years of age. She had symptoms since 6 months. Then she started medications, and after that, she had been doing well.
So for 8 years, she is generally okay without going into heart failure, right?
Yes, sir.
So that itself should give you some insights.
Is that a routine story of PH, or there are some PH which are rapid progressive, some are slow progressing? Suppose she had become symptomatic within 6 months. What kind of PH you would have thought? Or within 2-3 months?
So it can be because of some left heart lesion or.
So every disease has three issues: onset, progression, and the status. So this progression you have to keep in mind, because it is well known that there is varying progression, but this is somewhat slow progressive PH, isn't it? What do you think, Shiny? You want to comment on this? The course of PH. Sometimes we find that progress is quite slowly, whereas others go into heart failure much fast. So
yes, sir, I agree to that. So as you, sir, correctly said, the natural history depends upon exactly on what type of PH we are dealing with. And very rapidly progressing ones are usually the pulmonary veno-occlusive disease, one example where you can have very rapid progression of the PH and it may not respond to routine therapy. And there are very selected subsets of PH patients who are like a vasoreactive or responders who just tend to do well on medications.
So you have to keep that course in mind, right? So that gives some insights. Yeah, Shastri, any comments on this?
Yeah. The important point, it gives insight into the probable etiopathogenesis. The average duration of symptoms when the PH diagnosis is made is approximately 2.5 to 3 years. That is the usual idiopathic pulmonary hypertension. Sometimes you have got, say, for example, connective tissue disease, mixed connective tissue disorders. Sometimes they rapidly progress. Or even thromboembolic pulmonary hypertension, or you mentioned pulmonary veno-occlusive disease, the heart failure. They can sometimes, depending on the etiology of left heart failure, they can progress rapidly. On the other hand, my personal observation is, if somebody has genetic mutations, from childhood, they are predisposed, they'll slowly have symptoms. The symptoms, you should be very careful. See, in children especially, they would be just not playing as much as other children will play. Their activities are slow, insidious. They adapt to the lifestyle. They don't perceive it as symptoms. Even adults, I typically ask them, when is it last time you climbed a hillock or a multi-storied building? Then they'll slowly, the history goes back. Gradually, the more questions you ask, slowly you realize that the patient has been sick for a long time. Adolescent male will say he was never playing very well in the school or simple games where he doesn't have to exert much. So the two components are, it gives insight into the possible etiology, and also if the symptoms are so insidious and long-standing, you may be easily misled by what patient says in the first instance.
Right. Excellent. So briefly, just tell us why patient of PH have syncope?
Sir, in PH, the output is fixed. So whenever there is exertion or with exertion, they are not able to increase their cardiac output further. RV is not able to contract more, so they can develop syncope.
All right. So that's good.
So what are the other causes of exertional syncope in a cardiac patient? What does it mean? Exertional syncope in a cardiac patient means what? We're not talking about pulmonary hypertension. We don't know that this patient has pulmonary hypertension. A patient comes and tells you in the OP that he's having exertional syncope.
Sir,
What is the pathophysiology?
There is fixed cardiac output.
So what are the common conditions apart from PH?
Sir, if there is obstruction in the left ventricular outflow tract, aortic stenosis.
Yeah, severe, sometimes rarely even untreated severe mitral stenosis also.
Yes, sir.
They have dyspnea, but untreated they can have syncope, at least once I saw, and severe pulmonary stenosis. And rarely, not commonly, because you are pediatric cardiologist, sometimes arrhythmias can also trigger an exertion and pregnancy, but they're uncommon. Go ahead.
Okay, there is one question. I think we can take that. Can pregnancy worsen or induce PH? What are your thoughts on this? Somebody wants to know, Ashwin wants to know, can pregnancy induce or worsen PH? Surely it can, but what do you think? How will you answer that?
So there is exacerbation of PH pregnancy.
Sorry, say it again.
So there is exacerbation of PH with pregnancy.
Why? Can pregnancy induce or exacerbate PH? It can certainly exacerbate PH because
Pardon, sir?
it can exacerbate, it can worsen PH. Why would pregnancy worsen PH?
Sir, because
We'll come to the next. First, tell us why it worsens.
sir, in pregnancy there are fluid shifts and RV is already under strain in case of PH patients. Its functional capacity is already limited.
No, not necessarily. It may not be necessarily limited. You have a PH patient whose RV is all right, but even that will worsen.
So pulmonary vascular resistance also increases.
In pregnancy, normally in normal pregnancy, pulmonary vascular resistance increase or decrease? That's a good point. Let us see. Normally in pregnancy, systemic vascular resistance increase or decrease?
Sir, in normal pregnancy it decreases, but in PAH patients it does not.
The primary problem is cardiac output is doubled. So once the output is doubled, everything else remaining same, symptoms could worsen. And then there are other reasons why it can induce PH. Some people this is a typical story in an AST patient. Patient is perfectly all right before becomes pregnant, and following pregnancy 6, 8, 9 months, you realize there is a reversal. So something happens during pregnancy which worsens PH, certainly. But you should not lose sight of the fact that output is increased and that will everything else remaining same can also worsen PH. But in normal pregnancy, remember, PVRI is reduced. Your pressure does not go up despite doubling of cardiac output. Right?
Yes, sir.
Okay, let's go to physical examination.
So on physical examination, the BMI was low. There was no dysmorphism. Pulse rate was 82, regular, normal volume and character. There was no radiofemoral delay. BP was normal, JVP was normal. There was no clubbing or cyanosis, no skin lesions, no pedal edema. Saturation in both upper and lower limb was normal. In CVS examination, there was no cardiomegaly. There was parasternal heave grade 2. S2 was palpable. S1 was normal, S2 single and loud, and there was no murmur. Other system examination revealed no abnormality.
So What does this tell you? S2 single and loud.
Single and loud S2, it is suggestive of PEH.
Then on physical examination, we tell about how much is PA pressure likely. Is there? I mean, you are a pediatric cardiologist, but say in adults, there are some studies which have shown that if the second sound is heard at the apex, the PA systolic pressure is about 75.
Yes.
Some rough correlation. So how far is the PA second sound is heard in chest can give you some idea about the severity of PH, roughly speaking. But I want to ask you, when do you have a P2 which is heard at the apex but there is no PH?
So if the RV is apex forming, then
Like AST, for example. So in an AST patient, you can have a loud P2 which is heard at apex, but it doesn't suggest PH. Just keep that in mind. But otherwise, this is suggestive of PH, all right. So why PH gives you single second sound?
sir, there is a decrease in the hangout interval with increasing pulmonary artery pressures on the PA side. So this leads to S2 being single.
You sure you can explain hangout interval?
Sir, normally during the closure of the
It's
semilunar
okay.
valve,
Yeah, that's fine. We take that. Okay, so let's go forward. We have short of time somewhat.
sir, normally during the
Next. We take it that you understand hangout interval.
1 second, go back to the slide. Would physical finding will almost always rule out idiopathic pulmonary arterial hypertension or pulmonary arterial hypertension?
no, sir, it is not physical findings are
Which
not.
physical finding will rule out if it is there? It is not there in this patient. If it is there, which should make you think whether is this pulmonary hypertension or not. Physical findings. Somebody wrote PND, not talking about the history. Ejection systolic murmur. Ejection systolic murmur is not a sign of pulmonary hypertension. Ejection systolic murmur basically means either your cardiac output is increased or the valve is narrowed. So you don't have a narrowing of the valve here, outflow tract, either pulmonary or LV or RV outflow tract or valve here. And cardiac output by definition is normal or decreased. So if you have got a respectable, not respectable, any severity of ejection systolic murmur, or another finding is in this patient, of course, it's not there. If you find a wide pulse pressure, bounding pulse, generally it is not due to pulmonary hypertension, with exceptions. Maybe PDA, PAH, Eisenmenger, PDA, Eisenmenger with PR, things like that. But otherwise, it is not a sign. It's not a sign of idiopathic pulmonary arterial hypertension. So be careful about looking at the ejection systolic murmur. And coming to second sound, not in pediatric population, but my observation, which is not published, but maybe Dr. Kothari or KK can comment. If you have got a wide split second sound, apart from the ASD and all, even thromboembolic pulmonary hypertension tends to have a wider split second sound. That is because of the again hangout interval. Some areas of pulmonary vasodilated and some are not constricted, so that will impact the hangout interval, and S2 can be slightly wider.
I think so. I agree with you because I also found that. But I think we need to document it maybe somehow. But you should keep this thing in mind. So what we tell is that dilated pulmonary artery cannot give you any significant ejection murmur. So grade 1 murmur may be there, but anything significant ejection murmur will not be part of dilated PA.
Yes, sir.
Okay.
And like you were mentioning so many negative things, you should look actively. I mean, 16-year-old child is unlikely. But when you talk about pulmonary hypertension, you should always look actively for the bruise. If you hear a pulmonary vascular bruit, it is almost certain that you are looking for thromboembolic pulmonary hypertension.
Yes, sir.
Okay, go ahead.
What is the other cause of a bruit on the lung fields in a PH patient for a pediatric cardiologist?
Yep.
Sir, AVMs can be there.
All right. What else? Central pulmonary hypertension, but peripherally normal pressure. So peripheral PS.
William.
You have bilateral peripheral PS. You can have bruit. So which are the syndromes where you have peripheral PS bilateral?
The Williams can have.
Yes. What else? There are 3-4 syndromes.
And Noonan syndrome.
Not known actually. It's more known for LHLA and Williams and even rubella. can give bilateral peripheral PS. So this patient have a bilateral peripheral PS, but unless you recognize them, centrally there is PH. So they can masquerade as IPH. Okay, go ahead.
Yeah, one final important point when you're in the physical examination, it's a common teaching. Many people write in the books and talk in symposiums and all that pH is characterized by raised jugular venous pressure, tricuspid regurgitation murmur, tender hepatomegaly. These are all signs of right heart failure. They are not signs of pulmonary hypertension. Pulmonary hypertension need not be complicated by right heart failure till it's pretty advanced. So, if you wait to diagnose pulmonary hypertension based on the signs of right heart failure, you have missed the bus. So, you should be very carefully looking at the second sound and other signs, symptoms, of course, but don't wait to diagnose when the JVP is raised and liver is palpable.
Yes, sir.
So what could be the early sign in JVP, which you could have expected in this patient also?
Sir, A waves will be predominant.
Yeah, so dominant A wave we could look for, isn't it? That's true. Okay, go ahead.
ECG was done and it showed sinus rhythm. There is right atrial enlargement, right ventricular hypertrophy, and ST depression in 2-3 AVF.
So this 2-3 AVF is also very tall waves, no?
Yes, sir.
So 2-3 AVF represents right ventricle or left ventricle?
Sir, right ventricle.
You see, so many hypertensive patients have 2-3 AVF tall.
So this basically is representing the RV strain pattern.
In this patient, it may be RV, but in general, 2-3 AVF represents right or left?
It represents. It basically represents the anterior-posterior vector forces.
No, it doesn't represent anteroposterior. How can 2-3
In the
AVF
frontal
represent
plane, you
anteroposterior?
cannot have anteroposterior and frontal plane.
So every question doesn't have a good answer. It represents both ventricles. It's an inferior vector. So either RV or LV both can give you tall R wave in 2-3 AVF. It's commonly misunderstood thing. This is an inferior vector. So both ventricle and the hypertrophy voltages in the inferior leads are high. Right? There's no issue about it. It can be RVH or LVH. No problem. R in V1 in this patient, is this too much or what do you think is the RVSP? What do you guess right ventricular systolic pressure from this ECG?
So what are the patterns that suggest very high?
Pardon, sir?
No, answer Dr. Kotari's questions. Based on the R in V1, what the waveform, what is the likely PA pressure? Systemic, subsystemic, or suprasystemic?
Says,
There are some rules that tells you.
It will vary with the age of the patient, right? But in a 16-year-old, if I have R by S, which is nearing 1, it's not too bad, right? But the transition is occurring beyond V4, and there are ST changes which are suggestive of ischemia, maybe. So this is suggestive of significant pressure, but not suprasystemic pressure. I would think this is probably okay. It is looking like a systemic pressures.
So what do you need to have for suprasystemic? What tells you that what patterns suggest to have suprasystemic?
sir, the R wave RS ratio in the R wave will be much.
RS ratio, or do you talk about some other pattern that suggests?
Sir, there will be QR pattern in V1.
Yes.
And
That's correct. Okay. So QR certainly means suprasystemic pressure if there are no other reasons for that QR pattern. And otherwise you have to always integrate it with the age. You see, in an adult, this is very abnormal. To have a R bigger than S in a V1, this is very abnormal. But in a child, it may not be so abnormal. So it may be even normal in a 2-3 year old child. So that's okay. But the STT changes are taking away. Without STT changes, that would have been okay. But with the STT changes, are suspicious that this is severe PA pressure.
yes,
Okay.
If you follow these patients, PH patients over a period of time, what will be the first sign of ECG evidence that probably pulmonary hypertension is there? Early sign.
Just refresh, Dr. Shastri, what will be the ECG evidence that the pulmonary hypertension? I didn't hear the last bit of your sentence.
No. What is the earliest sign of ECG evidence of pulmonary hypertension?
Yeah.
What were the early signs?
early signs. Sir,
S in 1 and
the
AVL, S wave in right axis deviation, S in 1 and AVL will be the first to appear. Gradually they increase, then you have incomplete RPVB and start having the slowly increasing R wave in V1. Then the STT changes will occur in the precordial leads, then inferior leads. As the time goes on, pressure increases, then you have got ST depressions in all of the precordial leads and QR patterns come. So depending on the EC changes, you can be sure how long it is there and how severe. Of course, you have to account for the thin chest wall in young fellows. Go ahead.
the X-ray chest, it showed mild cardiomegaly, prominent MPA and RPA, and no evidence of increased pulmonary blood flow.
Something more?
Something more, yeah. Which chambers?
So right atrial enlargement is there.
Okay. And you're not telling about lung fields?
Lung fields, sir, looks normal. There is no evidence of increased pulmonary blood flow.
Is there evidence of decreased pulmonary blood flow? Is there pruning? So there is a very significant pruning. No? So periphery is quite not so. I mean, the vessels are not going as far as they should normally go. So you should say pruning.
Yes, sir.
Without question, there is significant peripheral pruning.
Yes, sir.
So MPA enlarged, RPA enlarged, peripheral pruning. And when do you call it RPA enlarged? You know that.
What is the radiologic sign of RPA enlargement in male and female? What are the thresholds?
Sir, it should be more than. It should be more than 17 mm in case of males and
So some 15, 16, 14, something like that, right? But what about a child? How do you say RP dilated in a child because you know that they won't be 14, 16. So then you come, this I think you should answer it as a pediatric cardiologist.
What do you compare with?
we will compare with the first. I'm not sure, sir.
Can't do too much. You can compare either with trachea or bronchus or something like that. Okay. Somebody saying right bronchus, somebody saying trachea. So we have to compare with the airways, right? Okay. So dilated RPA, dilated MPA, peripheral pruning, and what else? So what should you talk about? You should also make a comment. No, there is no parenchymal disease. No?
Yes, sir. No parenchymal disease.
So that's important because pulmonary parenchyma. Suppose there is a fibrocystic disease in the lungs, so that will show up on the X-ray.
Yes, sir.
The cardiologist should not become too much of a cardiologist. He has to look at the lungs and heart as a unit. No?
Also talk about skeletal malformations. If you have skeletal malformation, that can also contribute. So mention that. Obviously, it's very obvious in those situations, but talk about it.
Okay, so this is actually suggestive of pH, all right. You want to comment on a right ventricular apex or left ventricular apex? It's a very boring thing. But apex is normal, right? It's not a RV apex so far.
Yes, sir.
And what criteria you are using for RA dilatation?
Sir, it is involving more than 3 intercostal spaces.
There is one more better indicator where you draw 2 lines, and the upper line, lower line, like one line at SCCRA junction, another at the top of the aortic arch. And if the upper line is smaller than the lower line, that is a better indicator of RA enlargement, and that's really useful.
Okay, sir.
So this X-ray does show RA enlargement, significant pH, and no evidence of a shunt.
Yes, sir.
Suppose the patient like this with severe PAH but has a bilateral pleural effusion. What does it indicate?
Sir, I could not hear the end line.
Suppose the patient has got severe PAH like this on X-ray and also has bilateral pleural effusion.
Yes, sir.
What does it indicate? What do bilateral pleural effusions? Of course, you are a pediatric cardiologist, but what do bilateral pleural effusions in general mean?
Sir, it can be there in like in heart failure conditions, the pleural effusion, pericardial effusion, generalized pedal edema, and symptoms.
Pericardial effusion is uncommon in left heart failure. But generally, bilateral pleural effusion means advanced severe heart failure and has a poor prognostic sign. In the context of pulmonary arterial hypertension, bilateral pleural effusions should make you suspect pulmonary vena occlusive disease. That is one of the three important criteria to make diagnosis of pulmonary vena occlusive disease. Very uncommon, but if you have them, either you suspect associated left heart disease failure or pulmonary vena occlusive disease.
Okay, sir.
Okay, next. So what else we have?
So echo was done. Echo showed a structurally normal heart. There was a PFO and there was evidence of PAH. The RV function was preserved. There was no effusion and no evidence of any Abernethy malformation.
So how you can rule out Abernethy malformation by echo?
Yeah, I didn't understand. How did you do that?
So if like sometimes we may be able to see an anomalous channel which is draining into the IVC.
Well, some radiologists can do that, but if you can do it, it's good. So you have to see portal vein and you have to see normal portal vein draining into a normal place. That should be good enough. But most of cardiologists would probably not be able to do so. If you can do that,
It's
that's
not
very
echo,
good.
it is ultrasound abdomen. It's not echo.
Yeah, yeah, you can put that probe, change that probe.
So, in all PH patients now we have made it mandatory that at least screen for a ultrasound abdomen and from the probe, same probe itself, just to have a look at any abdominal channel draining and any doubt we immediately refer to the radiologist.
Sir, I'll just come to it, sir. I'll give you an instance in our institution. This happened. We've started to screen the IVC and the portal vein on a routine basis
Yeah.
when we do echo. It's very easy to see. It's incredibly easy to see. And what has happened is that after we started to do that, I think there are 6 or 7 instances where we've picked up a communication that wasn't earlier reported, and that changed the course of the patient's management. One of our DM students undertook this, got very involved, and he started doing it routinely.
Surely the radiologist can see, cardiologist can see, but
Certainly.
it's of course a matter of interest, especially in pediatric patients, more common. But definitely I appreciate it. It's a good thing.
Yeah, it's a good thing, but only thing is Abernethy spelling should be E. Abernethy is N-E-T-H-Y. Alright, just tell us this PAT 63. PAT 63, how do you measure PAT?
Acceleration time, we measure the time between the onset of the pulmonary artery systolic flow and the time it takes for the peak flow.
So is it from the onset of pulmonary flow or from QA? Onset from QA of ECG or from pulmonary ejection?
From pulmonary ejection.
Yeah, I used to get confused. So it's a pulmonary ejection. It doesn't take into account pre-ejection period. So it is from the beginning of ejection to the tip of the P. All right. You have the picture of this?
No, sir, this was 2016, so we have not
Alright.
used.
Okay. So are we dilated and are we hypertension, TR? Mild TR, but it is not aligned and confident branch pH, that is fine. Okay, so where are we? IVC is 10 and 5. So there is significant pH, anything more than 60, 65. Okay. So KK, what is the plan beyond this?
So it's a good. I thought we will discuss. We put a question out here, but before that, can you go to the next slide? We put in a little bit of a checklist for pulmonary hypertension on echo. And we'll show you this, sir, and Dr. Shastri can comment on whether there are additional things that we should be looking for. So these are things that we tend to do as a screening, where we tend to miss because we found that very often pulmonary vein stenosis is overlooked. AP window, PDA, very often they are overlooked and it's very difficult to sometimes spot them if you are casual. And of course, we talked about Abernethy, and we also recognize in infants, especially scimitar can, present with pulmonary hypertension. So this is one, and then we have this assessment of severity that we talk about of pulmonary artery pressures and systemic septal configuration, and then functional assessment and features of right heart failure. These are prognostic markers that tells you how the patient is likely to do. But additionally, if there are features that we should be talking about from your vast experience, Dr. Shastri or Dr. Kothari, can you just
one thing nowadays we are talking about the TAPSE to RV systolic pressure ratio, which will give a ventricular arterial coupling.
Yes.
So if it is more than 0.3 or less than 0.3, you get an estimate what is the severity of the RV function. It is being considered as one of the prognostic indicators.
So TAPSE in millimeters. TAPSE in millimeters divided by RV systolic pressure.
In millimeters of mercury, yes.
Okay, thanks. That's
17 by 51 or something like that. So another thing is the eccentricity index. The eccentricity index is also a good prognostic marker whether the patient is responding to treatment, whether he is worsening or improving.
That we are marked out by this end systolic septal configuration that is measured by the eccentricity index.
Okay. Yeah. And pulmonary artery size. If the pulmonary artery size is much more than 4 centimeters, I don't, again, maybe you people can corroborate. Recently, I started observing that if you have got a pulmonary artery systolic size more than 4 centimeters, you start listening to the early diastolic murmur. And of course, that's not a sign of prognosis, but the chance of aneurysm and in situ thrombus will start increasing. So just you can keep measuring the pulmonary artery size also.
Okay.
So there's two things more. The pulmonary size in general is a good thing, and 40 is way out. If it is 40, you should really worry about there's thrombus, etc. But in many patients, I have seen pH size maybe does not correlate with pressure so much. You can have a AST patient without too much of pH, and some patient have a large pH just without any good reason. So size is should be kept in mind, but should not be a deterministic thing. And this TAPSE, when the patient starts developing TR, then because of TR, TAPSE can change. So TAPSE is not very reliable when patient is severe TR. So
Right.
TAPSE can become more and when the RV gets TR. But yes, it's everybody talks of TAPSE, so we should know those indicators also. Now, I think we have covered, and this is very important.
Just like your trivial TR, you can underestimate PA pressure. Even with severe TR, you can underestimate PA pressure. If there is a torrential TR because of the organic tricuspidal disease, for some reason there is a tricuspidal integrity is not good, and you have got a severe tricuspid regurgitation in PAH, you will be underestimating the severity of the pulmonary artery systolic pressure, because the pressure head diffusion will be faster and you will not generate so much pressure, something like that, some physiological principle.
In adult cardiology, because heart failure with normal ejection fraction is a important cause of PH. So LA size is also important in this, because vast majority of them will have a slightly enlarged LA when that is because, and it's surprising, many times they can have severe PH. So patient with heart failure with normal ejection fraction, that means PH because of left heart disease, can also sometimes masquerade as a IPH. In adult cardiology, it's not uncommon.
Absolutely.
The LA size will give you the indicator.
This is totally important and different topic, because we are dealing with pediatric cardiology. I didn't check, but pulmonary hypertension as a phenotype C of heart failure with preserved ejection fraction is fairly common, and it becomes very difficult to differentiate whether it is idiopathic PAH or group 2 PAH because of the heart failure with preserved ejection fraction, so-called diastolic dysfunction. Then everything becomes important, including LA size, E by E prime ratio, then left ventricular hypertrophy, which is forming the apex, is it LV or RV? All these things become important.
Very good.
If you have got an intratrial septum, which is not pushed to the left side in the presence of dilated RA, you should suspect atrial septal defect. Sometimes sinus venous ASD, of course, you must be seeing all the time. You easily miss a sinus venous ASD. Many times I saw patients being referred as RA-RV dilatation, PA pressure of 50 and labeling as idiopathic PAH. If the intratrial septum is central in position, that means if the ASD is not seen, you must look for go by transesophageal echo and rule out SVC type defect. That is fairly common.
Yeah, just as a check, the student can answer this. When does TR does not indicate PA pressure? Patient is TR, but it does not indicate PA pressure.
And if there is the tricuspid valve is
No, not tricuspid valve, some other valve.
No, patient is TR, but whatever pressure we are getting from TR is not reflecting as a PA pressure.
if there is a associated VST, or if
Why?
there is a presence of
No.
Presence of?
if there is associated PR,
No, how
No.
PR or AST will change that? They won't.
It won't change. When there is
RPOT, there is present.
Yeah, so if there is a pulmonary stenosis, then you are not certainly knowing PA pressure. But I had something more in mind because I saw one patient with status inversus LTGA, and the TR was diagnosed as IPH because RV was connected to aorta. So unless you pick up status inversus, it really happened and that went on for a while. So if you have status inversus LTGA TR, that's not IPH. That's normal. Okay.
fantastic. Can you go on to the next slide? So what we did next, we'll have we did some investigations. We'll just go through this. Please carry on, Roma.
CBC, RFT, LFT electrolytes were normal. ANA was negative. Thyroid function was normal. Anti-pro-BNP was 83.
Which is also normal for our institution, right?
Yes, sir. Yes, sir.
NT-proBNP mentioned whether it is picograms per ml or millimoles. There are many centers.
The picograms.
Yeah. Like that's commonly used.
And 6-minute walk test, baseline saturation was normal. She was able to walk 320 meters. There was some dyspnea, and at the end of 6 minutes, saturation was 93%, which later on normalized after 10 minutes. The lung ventilation and perfusion scintigraphy was done. That was normal.
Stop here. Okay, go on.
Do you routinely do ventilation perfusion scan or CT pulmonary angiogram?
No, sir. Routinely we don't do, sir. Especially in the pediatric patient, there is some sort of a school of thought that BQ scan has less radiation compared to a routine CT. So unless you are strongly suspecting or a strong history, we go for a CT pulmonary angiogram. It's a screening purpose. Depending upon the patient status, we go for a lung function scan. Not routinely CT, sir.
Okay. The next slide, we got a question for the audience, and so the Dr. Kothari was asking how should we proceed, and would you please put up the audience?
KK, sorry. Before that, there is a question in the chat box.
Yeah.
Should TE be routine? What do you think?
Not at all.
Not at all.
I don't think so. But especially in children, you can see it anyhow. But suppose you are, say, TE is to be done if you are not sure with the transthoracic. Otherwise, there is nothing extra in a pH which you get by TE, unless say sinus venous ASD. That is actually very often missed. So if you with that kept in mind, there is no other reason to do a TE.
Yeah, I agree. If
I
it
agree
is
with
not a
you.
routine mandated, if there is a suspicion like ejection systolic murmur or central interatrial septum, and if you got lot of colors is a feature of shunt on echocardiography. Less colors are feature of idiopathic.
Okay, can you put up the questions and go for it? People have started answering in the chat box. Can you do that, please, Shruti? Yeah.
Yes, sure.
So we'll just take 5 minutes. You can continue to discuss. We just put up these choices in this particular situation.
So this is little difficult, because very often the choices are guided by so many other things. But yes, ideally, they say that in every patient of PH should get one cath done. Now, what do you think of that? So, a cath is a desirable thing, but if the patient is very sick, you may not do a cath also because there is a risk of mortality also if the patient is very sick. So with that provision, and it should be done by people who are doing it often. So can you just tell very briefly, when you are catheterizing a patient of PH, what are the precautions you will take?
Roma.
We have to ensure proper ventilation should be there. So we have to be ready. We have to keep things ready so that if we can do it electively ventilation also if the patient is very sick, or it can be done under conscious sedation. But sometimes these patients may require ventilation during the procedure. Secondly,
So the word is preparedness. You have to have preparedness for any eventuality in the form of any under ventilation. You have to have complete preparedness. How will you ensure preparedness that the patient doesn't have an event? Who are the people who should be present in the cath lab? How will you keep the system?
anesthetist should be there, and
Mostly will trouble you, but anyhow, what else? Then, So this is a wonderful concept, preparedness. So, what do you mean by that? Unless you tell me that patient of PH is sick, unless you tell me avoid pain, because they response to pain, hypoxia is going to be terrible. So unless you tell me avoid pain, I'm not going to be satisfied. First thing first, this patient cannot get catheter in and out, injection here and there, because he will get into trouble. So they respond poorly if they get any stimulus extra, because the system is fixed, as you said. So you have to avoid hypoxia. Somebody answered, Prerna said that. So you avoid hypoxia, pain, and all other stimulant which worsens pH. That is one. So you are prepared for any eventuality, ventilation, etc. Okay, done. What else? So how do they get hypoxic? If you oversedate them, they can get hypoxic. So what else? You are doing pulmonary angio. What is the precaution? You should avoid pulmonary angio. If you have done a CT, you need not. But if you are doing a pulmonary angio, don't inject into main PA. Inject into two lungs separately, so that there is a backup. So avoid pain. Be gentle. Don't induce SVTs, because once you put long loops, patients start getting into SVTs, and then the whole cycle starts.
And ideally, the best thing is to use a balloon-tipped catheter. Unfortunately, it's not available these days, but that's the way you can have high safety.
Which route is better?
Yeah, sorry.
Which route of cardiac catheterization is better? You want to do brachial or subclavian or jugular or femoral?
Sir, IJV.
What is the advantage or disadvantage of each one? So maybe you may not have done many. I'll quickly finish off. See, if you do femoral, in the presence of severe pulmonary hypertension, many times it is difficult to enter the pulmonary artery. I mean, you can enter, it takes longer time. If you do internal jugular vein, it just goes.
Naturally goes.
In a minute, you can just enter the pulmonary artery, especially if you have got a balloon dilatation. The advantage of internal jugular, you use the ultrasound probe, always use it. But nowadays, they say for adult, even femoral artery puncture, use the ultrasound probe. So use under ultrasound guidance, it is easier. And subclavian, you can always you can end up with a pneumothorax, avoid that, but you can use the ultrasound for that. Brachial in adults, sometimes we have done that. If the patient is simple, you can just float it, and it's much simpler for the patient.
Right. Okay. So the cath should be done if possible without hurting the patient. That is desirable. CT chest, whether CT should be a routine in every PH. I guess more or less it has come to that now.
I think so, because there are so many things you can miss easily without CT examination. A mediastinal tumor, mediastinal fibrosis, and veno-occlusive disease, and thromboembolism. If you do CT, I always insist on unless you have done a lung perfusion scan, I insist on a CT pulmonary angiogram.
Totally agree, sir. For routine pediatrics, we don't do CT unless strongly suspicious. But for all other patients, we have made a protocol that CT PA's pulmonary angiogram is done. And if you're suspecting primary lung disease, an HRCT along with that also.
Yeah, actually, if you do a cost-effective analysis, routine CT may not turn out to be cost-effective. But the way the current practice is, I think no patient will be not getting a CT done. So it's okay. And there are many surprises. So depends on how sure we are for what. But yes, so CT will be done. Can you just tell me what is the ABG in a primary pulmonary hypertension?
What do you expect?
You are catheterizing the patient. What do you expect the ABG look like? Arterial blood gas.
Roma, PO, PCO2. Do you expect what abnormalities do you expect with pH, PO2, and PCO2? Are you audible? Is she speaking? Is Roma speaking right now? We can't hear you, Roma.
We can't hear.
Hello?
Yeah.
Go ahead.
Just
Am I
tell us.
audible, sir?
Yeah.
ABG in IPH.
Again, yeah, go ahead.
Sir, saturation will be normal, and pH will be in the normal range usually. There can be little amount of hypoxia, like the PO2 can be on the lower side. And
what does that indicate if the PO2 is on the lower side? In IPH, what is the commonest reason for that?
so they can have some ventilation perfusion mismatch can happen, mild amount, but severe is not consistent with PH, but mild
Find
amount.
a PO2 in a patient, let's say saturation is 94% and PO2 is 73. What is the most likely reason for that in a IPAH patients? Simple thing. Okay, we can ask you when the patient is when the next data gets analyzed, because that's the exact numbers we found in our patient also. We can look at it. But what is the most common reason? And of course, somebody is answering correctly in the chat box right now. But
Okay. And what is CO2 like? What would be PCO2 like?
PCO2 will be normal.
Little low or little high?
Little low. They usually have hyperventilation. Like,
so if the PCO2 is high, then you think of some other cause, maybe primary lung disease. So IPH does not cause high PCO2. So if there is a PCO2 say 50, then you're dealing with something different, no?
Very often you find that anesthesiologist will say that, sir, because of pH, we are worried PO2 will be low. I mean, they have this notion in anesthesia and other areas that pH will produce alterations in blood gas. It generally doesn't.
Yeah, pH, ABG in pH, unless it's very complicated, severe advanced heart failure, is likely to be normal. If you have hypoxia, like somebody answered PFO, or very low output state, or even idiopathic PH can have some component of veno-occlusive disease, they can have VQ mismatch and go on develop some hypoxia.
So at this stage, can you just say causes of cyanosis in PH? I think we may be able to do only one case. Important aspect, so it's okay. If you allow cyanosis in patient of PH, IPH, is that okay? We can't hear you.
sir,
Cyanosis in patient with IPH of all severity, slight, severe, moderate, severe, very severe.
sir, in very severe there can be, in severe PH there can be some cyanosis, but usually with mild PH cyanosis is not there.
Because of what?
Pardon?
Why does the cyanosis come?
Sir, there is a low cardiac output and
Low cardiac output does not give cyanosis. That's a peripheral cyanosis, no? If somebody has severe PS, low cardiac output, that doesn't become cyanosed. Low cardiac output by itself does not cause central cyanosis. It will cause peripheral cyanosis.
Yes, sir.
Central cyanosis in idiopathic PH. One is PFO just now as we discussed, that's fine. So PFO or AST is possible. Patient is gross TR, PFO opens, there is some cyanosis. Other than that, I was interested in other than that. That is well known.
And we've seen actually one patient, she comes on our follow-up also, you guys would recall.
But there is some unroofed coronary sinus strain.
That is other cause of cyanosis in any patient. So that's okay. Somebody can have unroofed coronary sinus. That's not the answer, no?
So let's say this patient has some telangiectasia.
Pulmonary AVMs.
Yeah, so one will keep that in mind that there will be pulmonary AVMs as a cause of PH. So that is okay. Progressively cyanosis. I have seen some patient, Shastri, you can comment on this. As they go, severe PH, sometimes they develop bronchopulmonary anastomosis. And when they are in gross heart failure, they become unusually blue. Couple of patient PH I saw, very blue. And then you realize that, you generally thought that they may not be IPH. But later on, when they go into gross heart failures, there are sometimes bronchopulmonary vein shunting. And therefore they can become blue.
I agree with the observation, sir, but I am not sure of the mechanism. If you follow the PH patients for a long time, as the disease severity increases, they start becoming hypoxic and cyanosed.
Also,
I do not know, maybe it's bronchopulmonary collatus, but what I have been thinking is that even the pulmonary arterial hypertension, the pathology goes on to capillaries and venules also. So there will be a problem with the diffusion mismatch. diffusion abnormalities, and they may develop in the autopsy series. You see capillary and venular involvement in advanced PAH, so they may become hypoxic. But it is absolutely true. Another thing it is said, if the mixed venous oxygen is very low, then also they can develop systemic hypoxia.
Yeah. So that we are talking about mixed venous saturation of 40 or below, something like that. Very, very
absolutely.
low.
Absolutely.
These things, as the disease progresses, the lungs also get bad. No, so there is a localized collapse, compression. There is localized. So you have to keep this in mind. Sometimes they become very blue. But if you've been following them, then you know that they were not blue before. So these are a couple of reasons for cyanosis in them. Okay. Go ahead.
So cardiac catheterization was done, and the baseline did not reveal any presence of shunt lesions. The mean PA pressure was 64 millimeters mercury, and PVRI was 11.4, and PVRI SVRI ratio was 0.86.
What is the unit of PVRI?
Sir, Wood units.
No, it is PVRI is 11.4.
Sir, it is Wood units. Wood units into meter square.
It's a Wood units into meter square, no?
Yes, sir.
Not per meter square.
Yes, sir.
Okay. So
And I just want to know from pediatric Kothari and KK, is it really, in the absence of shunt, is it required to calculate QPQs?
not at all.
It's not required.
Not required. We just like put up the numbers. That's all. Just to show that there is no shunt or step up. That's all.
No, I'll tell you, I see 170 students are there. Other day I had a very funny situation. I'm sorry, just take 1 minute, KK, very important. A patient for heart transplant, they did a right heart cath. And there is mixing of the values, PA and SVC. Suddenly they found a cardiac output of 7 liters, QPQS 1.7:1 for a patient waiting for a heart transplant. Basic concept should be there that in the absence of shunt, you don't calculate QPQS and left right shunt, because the mixing of samples by the technician there can end up. We should know background that what case we are dealing with.
So in this particular case, I brought it up when they showed me the slides. I said, why are we showing this? The answer was that it is practically same, so it doesn't matter. But here, there is a marginal desaturation, which becomes a little more obvious in the next set of values, perhaps as a result of a PFO. But other than that, yes, I agree, it's absolutely not necessary.
No, but also there is a concept of step down. See, normally there should be no step up. Okay. If there is no shunt, there should be no step up. So if there is a step up, then you are supposed to account for the step up. So it is observed that in some patients, when the cardiac output is very low, there is step down. So PA will be lower than SVC, IVC. So step down suggests a low cardiac output. Just remember that. But if there is a step up, one should know the cause of step up, because normally you are not supposed to have a step up.
Yes.
But probably it depends on the number of samples you take, no, sir?
Yeah, no, one can put most likely it's a mess up of some samples or some air in the one sample and delay in samples, etc. So there's no reason to have a shunt in that setting. So, okay.
So,
you did vasoactive testing, is it?
Yeah.
Okay.
So we'll stop. Don't advance the slide. Let's have a discussion. And I think Dr. Kothari and then Dr. Shastri can also comment on this whole concept, because it's a very important concept we're going to introduce here.
It was given, and we saw that there was a fall in mean PA pressure from a baseline value of 64 to 48 millimeters of mercury, and PVRI also fell down from 11.4 to 9.5, the PVRI SVRI ratio being 0.6 against baseline of 0.86.
So we are doing vasoactive testing in a patient without a shunt to identify vasoreactivity, right? So if he's vasoreactive, you might try calcium blocker. So that is our idea. So is this a vasoreactive? Shall we conclude that this is vasoreactive? And we have given nitric oxide. It is pretty much the biggest thing we could do. 20 parts per million and 25% FiO2. Okay, we could even give 20, 40, 80 also. So the key question is this patient should be considered responsive? So because if he's responsive, we might try to give calcium blockers.
So that is the whole thing. We will talk about, Dr. Shine will elaborate on this concept of reactivity and the criteria that we are following. So maybe we can talk about it, Shine, the two criteria, the next slide.
Yes, sir. So, sir, as you can see the values, the mean peer pressure has fallen from 64 to 48 with a reduction, corresponding reduction in the PVRI. So in pediatric age group, we usually follow two criteria. The modified BAST criteria was specifically for pediatric, where we say the mean peer pressure fall should be at least 20% from the baseline. And the other one is the sit-bone criteria, which we use.
Can you show the slide on those two criteria, please?
Yeah.
Next one. Yeah, next. Yeah.
So these are the two criteria which we use. The 20% decrease in the mean peer pressure from the baseline for the BAST. And in sit-bone, which is the adult criteria, where there's a reduction in mean peer pressure by 10 points, and the absolute value of the mean peer pressure should come less than 40. So there is recent evidence that the sit-bone criteria, even in pediatric age group, predicts well the long-term responders when compared to the modified BAST. So in 2016, when we categorized this patient, actually we used the modified BAST criteria, because if you go back to the sit-bone, the data, we can see that there is a 20% fall in the mean peer pressure. But if you apply the sit-bone, the value after nitric oxide has not come below 40. So strictly speaking, the child doesn't satisfy the sit-bone criteria, but is positive for the BAST criteria. So in 2016, actually, we were more inclined in using BAST for the pediatric responders. So actually, we classified this patient as a responder. But as I emphasized, the recent guidelines, there is enough evidence now to say that even in the pediatric age group, the long-term responders are better identified by sit-bone than BAST, which is a little more stricter criteria. The BAST has not become obsolete, but some centers still stick to that one. And you depend upon the individual patients, you can take a call.
Show the next.
Really very important. So at this point, shall we give him calcium blockers? Because whichever criteria we follow, this or that, agreed. But to me, it doesn't seem that this child should respond to calcium blocker.
I would say one thing. See, if you look at the evolution of this criteria, the BAST criteria came first.
Yes,
so
sir.
She thought that the BAST criteria, the pulmonary reversibility is there, so they respond well to calcium channel blockers. But when these patients are followed for a long time, people realize that some of them fall off, that they no longer respond. That is when the sit-bone criteria came, I think 2005 or 6, when he came out with this criteria, based on the observation that only when you have got a PA mean less than 40, really they do well in a good number of patients. So if you see the evolution, it is based on the long-term response that the sit-bone criteria came, and they hold true till today. So I think you should go with, I don't know about the difference between pediatric and adult, but vasoreactivity is more common in pediatric population, that's fine. But you should go by sit-bone criteria, and only when the PA mean less than 40, then you can probably try with these calcium channel blockers.
So good thing here was that the PA diastolic has fallen very significantly from 50 to 30. So that is, what was the output like? Did the output also improve here?
It has come down if you look at the QS.
So QS has not, so that's not very encouraging. So my guess is that this child will not respond to calcium blocker.
So the only thing in that QS coming down was that, sir, if you see the mixed venous, actually it is 80 for the baseline and 76 for the so that could explain it. That was the thought which we went through our mind also, like the cardiac output has come down. But if you strictly see that it's not in the low cardiac output, diatic pressure has remained the same. The mean peer pressure, the mean diatic pressure was 70 for it against 68 with the nitrate. So we thought it could be a sampling error. So one has to keep in mind that these things also can happen in a cath lab. That is not strictly
taken. We'll accept. So
one more thing, Shine.
Yes,
there are so many students here, they should know, when you take these measurements, patient should be in stable condition for at least 10 minutes.
Exactly, sir.
And suppose the patient is sedated and suddenly he wakes up, and then the cardiac output will go haywire. Suddenly there's a noise, somebody shouting, suddenly a music has been played. Then all these things won't. There's a quiet room for 10 minutes, stable condition, then you take the numbers.
I truly agree, sir. I truly agree.
Can you show the next slide, because here's something that we've been doing, and again we'll invite comments from both Dr. Kothari and Dr. Shastri.
So we were trying to use intravenous sildenafil as an alternative agent for nitric oxide, because one common thing which we face in our institutions across country is non-availability of nitric oxide. So to address that situation, especially in a developing like milieu, we tried this trial of intravenous sildenafil for testing vasoreactivity in patients. We administered a dose of 0.2 milligram per kg in pediatric population, and in adults we gave a dose of 10 milligram IV as a single dose. The maximum pediatric dose was equal to the other dose of 10. So we published this paper recently so this is the first of all, this is the data which we got with sildenafil intravenous, which was almost like the similar to the nitric, though a bit low. The mean peer pressure has come down to 48. It was 50 for the nitric. So that was almost similar to the nitric inhalation therapy. The paper which was recently published, where we had 44 patients, 50% of them were pediatric, and 27 patients with IPH and 17 patients with congenital heart disease for assessment of operability. We found that the nitric more or less correlated very nicely with the data with with the IV sildenafil. We identified 2 responders for the whole group in the IPH among the 27 patients, and both were identified by sildenafil. So it could be that in our situation where nitric is not available, and if you are very keen on testing a vasoreactivity for a PH patient, sildenafil may be a potential alternative. I would invite the comments from the senior colleague.
See, I would have no problem with that. Only thing is the SVR with sildenafil also goes down. So,
Exactly, sir.
so what is the proportion of the values might be a little different, but conceptually it should be okay.
Yeah.
Your RP by RS values may be different. That we need to have a larger number of patients to understand that how much SVRI goes down. Because in some patient SVRI is very little, in some it may be more.
Exactly.
But conceptually it is okay. And if you are not having nitric, you might as well try this.
Yeah.
That should work.
I'm not sure I agree with this Shine and KK.
Yeah.
The reason is, there are multiple reasons. See, sildenafil will definitely be more sensitive than nitric oxide. There are other papers also, you must have reviewed the literature, which show that sildenafil is more potent than nitric oxide when you give intravenous, number 1. Number 2, in general patient population, what do you do when the patient is vasoreactive negative? You give sildenafil, and a good number of them do respond. They do well. You may not be doing hemodynamic monitoring, but in the super trial you have shown that there is a fall in PVR and all, original the Pfizer study of super study. So sildenafil does work where nitric oxide fails to work. Number 2. Number 3, you should follow these patients, just like the difference between Bosch and Sitbon criteria. Unless you demonstrate to me that after having given sildenafil and you showed the same numbers and you followed them for few years, then you say that the sustained response is there with calcium channel blockers. The question is whether they are responding. You are going to give them calcium channel blockers or sildenafil, isn't it?
Exactly.
Suppose you do a sildenafil study and give sildenafil, what is the use? On the other hand, suppose you do give sildenafil acute vasoreactivity test and demonstrate fall in PVR to PVP mean less than whatever, 10%, 20%, whatever the number, and show down the line 2 years, 5 years, 7 years, what is happening, how they are responding to calcium channel blockers. That is the test that you should do.
Exactly, sir. That point is well taken. Like, I'll just simplify that. The point sir made was that here we are only looking at the acute situation in the cath lab where the patient is having a response to the sildenafil or nitric, and this has to be sustained in long-term follow-up. And if the sildenafil predicts that, then it would be a useful alternative. That's what I think sir mentioned.
Absolutely.
All well taken points. Can go on a little more in the interest of time. So here's the question that we've put together at this stage, and we'll discuss what was done in this patient, but we can put on the poll questions, Shruti. So just for the sake of the audience, PDE5 is inhibitor is sildenafil tadalafil, and ERA is endothelin receptor antagonist.
How do we know who is Acha will come now? The scores will come. Okay.
We'll get the answers.
Yeah.
I think you can put up the polls. So we've got a varying answers, isn't it? Very interesting. I expected that because it's not so clear from this data. But now we can have the comments from the two experts and we can then show what we did.
So this is a little difficult situation. You see, one must identify those who are going to respond to calcium blocker even for a few years, because if they respond well. They respond really well. But this response is borderline, and I would be very worried of other way around is if you give calcium blocker in somebody who's not real responder, it might worsen. Yes. Now 20 millimeter diastolic fall, and there could be mixed group also. So there could be a patient who is going to respond little bit. It's little vasoreactive, but it's not the whole thing. So in this patient, I would probably start calcium blocker and PDE5 together. And recognizing that probably his response to calcium blocker is not going to be very long, but it may be. And I am basically putting all this because 20 millimeter diastolic fall in PI tells me that there is some vasoreactivity preserved, but it's not entirely vasoreactive. So I will not leave him alone with calcium blocker because he will probably not do well with calcium blocker alone. So I will agree that probably he would have also gone with D, and I would like to see what happened on follow-up.
Dr. Shastri, what is your?
I would strictly go by sit-borne criteria, as I mentioned, the way they evolved, and I would consider him as vasoreactive negative, and give him a combination of PDE5 inhibitors and androgen receptor antagonist. My choice will be B.
Yeah, sir. Just one question to Shastri sir. Like, if you were in 2016, where this data hadn't come out, like sit-borne is also applicable to pediatric.
No. Achha, about pediatric, I don't know. Yes, at that point, I'm not a pediatric cardiologist.
No, but
because I tell you, I wrote a review article in 2008. So by the time the sit-borne criteria was very much well established, so I am familiar with those criteria. So I don't know the applicability to the pediatric cardiologist.
Okay, sir. So actually, what happened was that, as I told before, the recent strong data of using sit-borne in pediatric has just surfaced 2-3 years back. That there's always a contention like which to use. So actually, we had gone by the BAS criteria in 2016. We are not much applying the sit-borne to the pediatric population, and there are institutional biases with that. We had gone ahead actually with I would agree with the audience poll, like it may not be a bad choice.
So Roma, you can move on to the next slide and we can show what we do.
Yeah. So actually, we had started from calcium blocker, and nearly followed up for 8 years. She had absolute resolution of symptoms in function class, and echo has been good. The RV function has been preserved. And last visit, her NT-proBNP is 22, 6-minute walk distance is 480, and she's still on amlodipine 5 milligram twice a day. We are trying to step it up. But there are some concerns, like the peer pressure has not completely become normalized or in a very good value. There is a bit of end-systolic flattening in the last echo also. So we are contemplating whether we should switch over to the next level of vasodilators or upright rate on calcium blockers and C.
So we can have the next question. Again, there's another question that follows this, I think.
But what is the RV function like? Is the RV function
RV function is preserved, sir, normal.
Is it same as before? It seems to be a little worse on echo.
No, sir. TAPC is worse. The TAPC is good. Fractional area is 36%. BNP levels are normal.
Dilatation size-wise?
Size-wise, it's almost remained the same, sir. I would agree to that.
See, but LV eccentricity is still there.
Still there.
I mean, doesn't mean that RV dysfunction is there, but the PA pressure load is there.
Yes.
Yeah. Okay, I think you should catheterize him and probably add ERA,
Yeah.
Yes. So would you add, what would you choose? So we can have another question at this point and we can discuss these choices because I think there is some data which favor each of these choices.
Well.
Dr. Kothari said you will choose two things of these two, which is catheterize and then add a medication. I am inclined to do that, but let us discuss the medication choices also.
The whole literature on medication choices is very subjective and evolving, and there are no really good reason to do one versus another, as far as I can understand. The argument is that if the patient is sick enough, you start together so that he may feel better. What is not recognized in this is there a tachyphylaxis to this medication? And nobody knows this. If you continue ERA and sildenafil, are the patient going to lose the effect over time? And my worry is that they just might be. So what I tend to feel is that if the patient is moderately sick, I like to keep something in reserve. Now, is it a good idea or a bad idea? Not very sure. If this patient is not worsening, I would probably add one at a time. maybe. That in an individual case, I would probably like to do that. Instead of hitting him with both, now, argument is that if you hit him with both, maybe he does well over years. So my critical question, to which I don't really have a good answer, but I'll put it to the audience: is there a tachyphylaxis with these drugs? Answer unknown. It may be.
Dr. Shastri, in light of that study that looked at the better value, higher value of combination therapy, I forget the name of that study, and that study showed that if you start the combinations, you tend to have a better outcome, at least.
Yeah. There are actually 3 trials, and 2015 ESC guidelines also show. Instantly, CIPLA yesterday had conducted a meeting on page only yesterday. Yesterday was pulmonary hypertension day. So there is one expert from Belgium. He was saying, and of course he's one of the task force members, and the 2015 guidelines clearly show that except in some situations, now the recommendation is to give a upfront combination therapy of both PDE5 and ERA. The trial, one of the first trials was the Ambition trial, which has clearly shown the primary endpoint well met, and the NT-proBNP levels and 6-minute walk test, everything was changed favorably when you give upfront combination. Of course, there is no mortality difference, but hospitalization has improved significantly, and hospitalization is a good predictor of the future mortality. So I think there are other couple of trials are there. So I would give combination of PDE5 and ERA. I do not know about tachyphylaxis, but there is evidence to show that the rate of progression of the disease is altered when you give upfront combination therapy.
If the patient is class 1 or 2, will you do that? If the patient is class 3, I'm sure you do that. But
No, class 2 also.
2, yeah.
Class 1 very rarely we see, but class 2 above we do.
Yeah.
So Shastri, Shine and I have slight difference in styles. I tend to be like Shastri, fairly aggressive and start with the combination because I believe that we need to do best to remodel the pulmonary artery and improve the prognosis. Shine goes stage-wise. I've noticed very consistently he takes one drug at a time. So what is your rationale, Shine, of doing one drug at a time?
The main thing in our population is cost, sir. The main thing, sometimes when you add the dual therapy, there is definitely a financial issue in our setting. So, as Kothari sir pointed out, unless the patient is in class 3 or 4, I usually don't start on upfront combination therapy. But as I would agree to Shastri sir also in the sense that there is a lot of emerging data that upfront combination therapy, even in a functional class 1 patient, benefits long term. With respect to the catheterization in an IPH and identifying the responder, the good thing is that you can put them on a low cost medication fairly well for a long period of time, which is very important in our setting. You can maintain them on a catheter blocker if they're a good responder for a long period of time, reasonably long period of time, which can definitely reduce a financial burden on the families because all these medications are reasonably expensive and at times they tend to stop just because of that matter.
So if she responded a little bit, you could probably have given higher dose, because calcium blockers have to be given in much higher dose.
We are going up, sir. We are going up.
We've been given quite high doses, actually 5B. How much is it? Which we're giving right now? It could be even more. That's what Dr. Kothari is saying. You can give very high doses.
Should go a little higher than this also. And that's a great, this is slightly surprising response because I didn't expect that she would respond so well. It's very good. So we have saved some, so there's basically we have done some good. Now probably we should add other things also so that we can continue to feel better.
Yes.
A couple of things I will say, Shine.
Yeah.
You don't mix up the medical decisions with the financial decisions.
I agree, sir. I agree.
Suppose
It's very hard, sir, because they're taking everything. They say it's so costly, we can't afford anything.
Let them say that. Your advice will be, suppose a patient requires heart transplant, bypass, I'm talking about enteral cardiology, TAVR or whatever, some surgery or congenital heart disease, some congenital TIVOF repair. You don't say because the patient cannot afford, I will go for PT shunt. You won't say that. You advise. What the patient decides is his choice.
Yeah.
And coming to the calcium channel blocker, there's just quickly I make one point. There are two things. Actually, sometime back there is a study, I think from this one of the centers which does a lot of work. There's a genotypic predictions are there. Some genes, some genotypes, they show the response to vasoreactive positivity and response to calcium channel blockers. Interestingly, I came across a case report in which patient was not responding very well to triple drug therapy, including Selexpag and ERA and PD5. And at that stage, they decided to do a vasoreactive testing, which came out positive. They gave calcium channel blockers, and patient responded dramatically. So there are certain gray areas, unknown things in this. So we can never be dogmatic about these things.
That's very good. So I just tell one anecdote. One patient, I just gave amlodipine and she refused to stop that drug. She feels so good with that drug. So, there are things more than simple these things. So you can keep and try, but by and large, calcium blocker can be harmful to them also, no? By causing vasodilation. So once you make sure that it is not harming, then you can take your choice. And so there's a wonderful case. If triple therapy is not responding and calcium blocker they responded, that's a very
But that should not be a guideline.
That's the
It is an
exception.
exception. Always do a vasoreactivity test, wonderfully done by Amrita people. That's how we should treat the patients.
But very few respond. I would have only a couple of maybe 4 or 5 who responded to calcium blockers. So, and I thought once the PA pressure goes above 50 mean, there is no question of response. But this patient is quite unusual, and that's very good.
In children, the response rate is almost 35%. In adults, it's about 15-20%, not less than 20%.
They so 30%, but it's actually not there because see, this data comes from them where the PA mean is usually 30, 40, 50. Most of our patient PA mean is above 50. So I think in our setup, response is not more than 10-15%, even in children. What do you think, Shine?
I would agree to that, sir, because in our study also 27 patients, only 2 had response. And I think till date for a pediatric age group, I would have seen hardly 6 or 8 responders who are on
Something
calcium.
like that, because we see the tip of the, top of the disease spectrum actually. Okay, so how far do you want to carry? We are nearly touching 8. And we are not finished one case.
We'll finish this case, sir, and as you suggested, we will reserve the second case for another occasion. That's an extraordinary case, really. The second case, because we shared only the first set of slides with you. What happened thereafter was very interesting with that patient, and I think that merits a very in-depth discussion. And I think what you've done for this case itself has been fantastic. So we are coming to the close of today's session. We just have 5 more minutes. So we can wrap up at this point of time and maybe just summarize the key messages in terms of how we evaluate these patients. So I think I'll just take closing comments from both of you and we'll wind up, sir.
I think there's a lot of learning around this case and I think we've done well. That's all from me.
Dr. Shastri, key messages?
You are done. This is how the case should be managed. I congratulate you people and a very nice case discussion. And I wish more and more people have basic knowledge about the hemodynamics. What bothers me, KK and Dr. The problem is most of the interventional cardiologists don't know how to do right heart catheterization. They mess up. They don't know how to differentiate between a damped PA pressure and pulmonary artery wedge pressure. And all kinds of things, whatnot. So students, I believe there are so many students, as part of the training, learn basic hemodynamics. Pediatric cardiology, KK, you people breathe in and breathe out the hemodynamics. And adult cardiology, I won't be surprised if they don't know how to express the atrial pressure and wedge pressure. How to express.
You're overestimating our capabilities. We also have, there are also reasons why we have to emphasize the need for hemodynamics in pediatrics. Of course, it's more important here, but it's also it's also suffering a little bit from, from the onslaught of devices which are used.
Yeah. KK, I just missed one. If you want me to summarize a bit of it, I just want to add one point that, this is all is very fine. And now more and more people, there was once upon a time, people looking after PH were very lonely. And now so many, because of things have come up, so a lot of PH has been discussed. But in a patient context, see, this is all textbook says, and all this is very good, very important. But beyond this, there are patient-related factors. In an individual case, it is always there something which you can do more, like treating anemia in that particular patient, looking after what he really wants, not advising him things which are torturesome, like home oxygen. Very often you give home oxygen to PH patient, not needed. avoiding a hernia surgery, which could have been killing. So individual and maintaining optimism, because this patient will live for 10 years, 12 years while they are feeling sick. So maintaining a moral optimism in a particular patient, looking after his other medical conditions, that goes a long way in addition to all this.
And of course, once they reach this,
those things are important,
and pregnancy advice on pregnancy and contraception becomes incredibly important also.
Vaccinations. Now, one thing, another comment, KK. See, it's not, now the pulmonary hypertension is not just a domain of idiopathic pulmonary hypertension, all these rare diseases. The heart failure is preserved ejection fraction. Where they are patient presents with pulmonary hypertension, you should have a clarity whether it is a diastolic heart failure of the left ventricle or idiopathic pulmonary hypertension. The differentiation becomes very important, and these concepts are very important there. And similarly, we are likely to see more and more patients with advanced heart failure requiring LVAD or some mechanical cardiac support or say the heart transplant. Again, the basic concepts and knowledge about the pulmonary vascular hemodynamics is so important, and I urge all the students to become familiar with this.
With that, I think we should close. I think it's been fantastic. Really would thank both Dr. Kothari and Dr. Shastri for tremendous inputs and really great learning from, and of course, good presentation from Roma and great support from Dr. Shine. Thank you all again. We will come next week. We'll take a break for a month, and after that, we're having some interesting topics that Shruti can just show the next slide. The next set of two master classes will be on how to develop a career as a cardiologist. So we're going to have some very interesting discussions. So it will be on June 3rd and 2 weeks thereafter. So we will have some very good insights from a variety of cardiologists who are both in academic and practice settings, and we can have something very useful coming for the students. Thank you.
Thank you, KK. I learned more than I probably contributed. It's very great learning experience. Thank you.
Thank you.
Bye.
Thank you, sir. Thank you.